Thank you very much. The next speaker will be Robert Saper, the Director of Integrative Medicine at Boston Medical Center.
Good afternoon, everyone. I'm proud to be at BMC, which is the largest safety net hospital in New England. Dr. Benson described the incredible discoveries of penicillin for pneumonia and streptomycin for TB and how that dramatically changed the landscape of those illnesses. Those acute communicable illnesses have been replaced by non-communicable chronic diseases such as diabetes, cardiovascular disease, obesity, and cancer. Whether it be pneumonia and TB or those diseases like diabetes and cardiovascular disease, tremendous disparities exist in terms of the prevalence between socioeconomic status groups. So individuals who are white and more well-off and better educated had less of a risk of dying from pneumonia, whether it be before penicillin or after penicillin was discovered, and also incurring heart attack. At our center, what we're interested in is the following. If you look at national studies in the use of complementary medicine, you also see a disparity. You see that there are 2- to 4-fold differences in the use of yoga, massage, acupuncture between whites versus non-whites, high income versus low income, highly educated versus high school education. So the question we try to address is, can integrative medicine reduce health disparities? And if the answer is yes, then from a social justice point of view, not allowing or having these therapies available to everyone is really not just. And so for that reason, we founded the Program for Integrated Medicine and Healthcare Disparities with a mission to substantially impact the quality of life for the urban, underserved, through providing access to integrative medicine clinical services, research, and education. These are some of the clinical services that we offer. All of these services are either free or on a sliding scale. And if someone's not able to meet the lowest level of that sliding scale, it's a very simple process to have that waived. We offer acupuncture and massage, which are, you could say, almost traditional CAM therapies now being offered, as well as consultations. Integrative medicine group visits you heard about from Dr. Gardner, that's an innovative activity that takes advantage of 2 factors. Number one, the network or community that's created with a group of patients and practitioners that's very different than the traditional dyad of doctor and patient. 2, it takes advantage of the education that goes on between those different individuals that rises above just the individual, again, patient and doctor. We're also involved in the Cancer Center, and we offer yoga classes as well as Tai Chi classes. The next thing I want to speak about is our research. And so the first research study is Back to Health. And Back to Health is a comparative effectiveness randomized controlled trial between and that's the second one here, between yoga, physical therapy, and education. 320 participants with chronic low back pain that are recruited from our community health centers, predominantly low SES. The key point here is this. What is the bar that we have to meet so that a CAM therapy such as yoga is mainstreamed into healthcare? And what we would say is that it should be equivalent to a reimbursed common approach, such as physical therapy for chronic low back pain. So this is a non-inferiority trial to see if yoga is as good as PT, and preliminary unpublished results at 12 weeks show that yoga is indeed equivalent to PT in terms of reducing pain intensity, improving function, and also medication use. The first study is Dr. Gardner's study funded by PCORI, looking at this integrated medicine group visit model at BMC and 2 of our community health centers for patients with pain and depression to see if indeed it is superior to usual standard care for those conditions. We're also part of a national network of institutions, 16 across the country, for integrated medicine research called BraveNet. Music and massage are nice, but are they necessary? And that's what our study is looking at by bringing music therapy and massage therapy onto our inpatient floor, 6 West at BMC, seeing if it really can impact the triple aim, which is reduce cost, improve patient outcomes, health outcomes, and improve patient satisfaction. And lastly, we've just received a grant to tackle such a challenging problem, the rising epidemic that is being created with our returning veterans with PTSD and associated other mental health disorders, using yoga for chronic low back pain. Given that there's such a stigma around those psychological disorders, using the back pain, which is a very socially acceptable reason to see the doctor, have that be the entree and see if yoga can make an impact on that. So thank you very much.
Thank you. The next speaker will be Richard Glickman Simon, who's the Director of Pain Research Education and Policy Program at the Tufts University School of Medicine.
Good afternoon. Pleasure to be here. At Tufts, the emphasis is more on the education side than the research side, so I'm going to focus on that first and then get to a little bit about research. The first is aspect of our educational initiatives have to do with the undergraduate medical program. And it's an interesting challenge in the crowded medical curriculum to first try to emphasize this type of material and to think of an appropriate way to educate self-selected allopaths to view this type of therapy as appropriate. So we've historically done that in a number of ways. The first way is through the evidence. So as part of their evidence-based medical curriculum, we use integrative therapies as a model for studying the challenges, and it makes a great model for teaching evidence-based medicine. And then we go on in the clinical years to talk about, assuming that they're going to be straight-up conventional, most of them straight-up conventional allopaths, how can they help their patients without necessarily being trained at all in any of these types of therapies? What's the minimum standard in order to provide quality care? And how far can they go along a sliding scale to actually integrating these therapies? And this also entails the nature and use of clinical placebos, which generates a lot of fascinating and ethical discussions. And then one thing that we do in the clinical years is, which I wish we could do with other clinical services that our students are involved in, is have them actually be patients rather than just clinicians. The integrative model actually makes that fairly easy because of its well-renowned safety in most areas, as opposed to surgery, for example. So we can't ask our students to undergo major surgery, but we can have them actually have acupuncture and have their back adjusted. So we do that. And we discuss that experience. And in fact, they go and have a Tai Chi class with Peter as well. And that generates some interesting discussion about efficacy and how in the future they're going to treat their patients. Another thing that we've done, this is outside of the undergraduate medical program, but we have, as mentioned, we have a master's program at Tufts in pain research, education, and policy. This was developed over a decade ago in recognition that pain education for all allopathic health professionals is wanting from a number of sources of outcome data. And so what this program does is it invites clinicians and non-clinicians alike who have dedicated themselves to the treatment of chronic pain to get more education about pain in all aspects of it, as the name implies, research, education, and policy. About halfway through, about 6 or 7 years ago, we instituted some coursework in evidence-based complementary and integrative medicine, and then we partnered with the New England School of Acupuncture. New England School of Acupuncture, I'm sure everybody, or almost everybody, is familiar with NISA. They're the first, so they're the oldest acupuncture school in the United States, and they're right down the road here in Newton. And Tufts partnered with the New England School of Acupuncture to develop a dual degree program. So now NISA students can come to Tufts, and in addition to getting their master's in Oriental medicine or Chinese herbal medicine, they can also get a master's in pain research, education, and policy at Tufts simultaneously. And that's proved to be fairly popular among NISA students. Let me go. One other one of the slide that's missing is a couple of postgraduate or graduate medical education initiatives with the University of Arizona. They have an integrative medicine in residency program and a fellowship program. So Tufts family medicine residency, which we're going to hear from a speaker who's affiliated with the Cambridge Health Alliance, actually has a cohort of residents who take an online course during their residency program, plus have on-site training. So when they finish their family medicine residency, they're also trained to practice integrative medicine at a fairly sophisticated level. And we also have a partnership with Maine Medical Center in Portland on a number of levels, mostly undergraduate, but there they have that program as well. And they also have a fellowship where residents can take an extra year and get even more advanced training in this. And then finally, just a couple of points about research initiatives, and I'll quit. There's a Center for Complementary and Integrative Medicine in the Department of Rheumatology at Tufts Medical Center, directed by Chechen Wang. And because it's a Department of Rheumatology, the outcomes of interest there are rheumatoid arthritis, fibromyalgia, and related diseases. And she's particularly interested in the effects of Tai Chi and other mind-body therapies on those. And then the Freeburn School of Nutrition and Science Policies at Tufts, who has an affiliation with USDA Nutrition Research Center, where we study fairly extensively dietary supplements, including antioxidants and probiotics. Thank you.
Thank you very much. The next speaker will be Zeb Schumann Olivier, the Executive Director for the Center of Mindfulness and Compassion, Cambridge Health Alliance.
I'm so glad to be here. I have so much gratitude for so many of the teachers who are here that have taught me along this way, so it's kind of amazing to me to be able to be up here with all of you right now. It is a unexpected story about what's been happening at Cambridge Health Alliance, and I'll tell you a little about it. About 10 years ago, Chris Germer and Ron Siegel started a continuing medical education program for meditation and psychotherapy through Harvard Medical School, and that had a very strong response, and there's been a deep interest in mindfulness and compassion-based interventions within Cambridge Health Alliance. About 2 years ago, actually one of the residents here, Adam Elias, started a meditation sitting group among our staff and invited anyone from CHA to come. After several years of having just retreats open to everybody at the hospital, there was a network of about 200 staff members who started to talk about the idea of somehow coming together and forming a center. And a resident that's not here, a PGY1 intern, actually proposed the idea to the CEO and got his attention. And from there, the Center for Mindfulness and Compassion was born. So I'm here representing, I think, this team of people within our hospital system. I should say Cambridge Health Alliance is a community-focused healthcare system in the Metro North Boston area, serving about 7 Metro North Boston cities with about 130,000 patients. We envisioned a center that had 5 different areas of activities, including patient care, integrating into every level of patient care at the hospital system, looking at provider-employee self-care, having a robust professional education and community training program. We also have a commitment to all of the communities within our network and have already started to begin working with schools and other community partners to develop mindfulness and compassion-based programs, as well as several scientific research areas that we're working on, and we are here today because we're looking to collaborate. I'm going to tell you about one research project that has really brought together all the energy of the hospital system, and this is our Mindful PC project. We looked at the Affordable Care Act and the way that it has recommended the implementation of patient-centered medical home models across primary care. And when you look at the writing, it talks about there being wellness and potentially even mindfulness integrated into the patient-centered medical home but it doesn't really give you a pathway to do that. So we decided that since we had gotten this Delivery System Transformation Initiative grant through the Affordable Care Act as part of one of the safety net hospitals in Massachusetts, that we would integrate mindfulness interventions directly into our patient-centered medical homes across the 12 different health centers across the 7 Metro North Boston hospitals, 7 Metro North Boston cities that we work within. So we are actually beginning to train providers, our mental health care providers that are the integrative behaviorists that will be entering into the primary care centers and the patient-centered medical homes to be able to deliver mindfulness-based interventions. And we're also training as many primary care providers within our system that are willing and open to receiving that training. And we do have funding for this through an Arthur Vining Davis Foundation's Healthcare System Transformation Grant, as well as the Gold Foundation for Humanism and Medicine, as well as the hospital. And we're hoping to train 1,000 patients in mindfulness, 500 in a 8-week mindfulness group, and 500 in a brief introduction to mindfulness group, as well as, and we're using a 2x2 factorial design so that we can look at the effects of both provider training and patient training on the PCP patient relationship, as well as various different behavioral health outcomes, both through our electronic medical record, as well as through some other ways as well. Again, we have this large-scale recruitment effort across our hospital system. We're looking for opportunities to collaborate with other centers. We recognize there are other hospitals in the system that have some very advanced neuroimaging, genetic, physiologic tools that we'd love to be able to help recruit for. And so I think that's where I will end for now. And I really appreciate the opportunity to be here.
Thank you very much, Zev. The next speaker will be Ted Kapchuk, the director of the Harvard-wide program in placebo studies and the therapeutic encounter, PIPS, Beth Israel Deaconess Medical Center.
Good afternoon. If you look at the picture on the right, those are some pills that were used in some of our experiments. Inside the pill is mostly microcrystalline cellulose, which is purified dust. People, when I was first hired to work at Harvard Medical School by David Eisenberg, one of the things I was told was I had to rehabilitate myself in a positive way. And I studied with some of the great minds of the medical school, and they're really great minds, but I'm going to say something that makes it a little bit sarcastic. And one of the things I was taught was we really have to show whether these CAM therapies are more than the placebo effect. And I never heard of the placebo effect in China when I lived there. And I asked, so what's the placebo effect? And they said, oh, it's the effect of an inert substance, which of course is an oxymoron. Microcrystalline cellulose doesn't do anything to the human body. That's why we use it inside placebos. It's dust. So what exactly is the placebo effect? The placebo effect is actually everything that surrounds that pill. The picture on the left, or the left. And that includes words of kindness, acts of decency, the laying on of hands, commitment to be present, and being an empathetic witness. It includes rituals, words, silences, attentive listening. It includes an incredible amount of stuff. And what placebo studies does is use the fact that our culture has developed this technique of giving people fake pills to separate out something called an active ingredient from all the things that surround the active ingredient and quantifying it. And it's really not much more than the actual common ingredients all healers have. The program in placebo studies has lots of collaborators, thank God, and I'm going to mention a few. I was asked by Helen to speak about the Martino Center, which actually is silly because Vitaly Napido next to me is a very important component of the Martino Center. But Martino Center has the largest set of NIH grants around CAM in the university area, especially in terms of acupuncture and expectation and placebo. The PIs of our program project, which is now in its 7th or 8th year, are Bruce Rosen, Randy Golub, Kong Jen, and Vitaly Napido. Besides being involved in the program project, all those investigators have RO1s in placebo and/or expectation. It's an incredible team. Also, I want to mention at the Martino Center is Karen Jensen, who demonstrated that recently demonstrated that placebo effects can be activated non-consciously, which is obvious to any human being, but it was important to demonstrate that in the medical literature. And also recently, neuroimaged physicians' brains while they're treating patients and showed an interesting overlap with the placebo effect. The second place I'd like to mention some of the collaborators of the PIPS program is the Beth Israel Deaconess Medical Center. Tony Lembo is a GI doctor, has done incredible work of demonstrating that one can break down the complete placebo effect into component parts and then put them back together in a way that's analogous to a dose-dependent relationship. That's pretty cool, right? It shows that placebos can work like a drug. Another person, he's also another person at the BI is Rami Burstein, who just studied randomized 459 migraine headaches and was able to disentangle the placebo effect from the effect of rosatapine, max salt, and demonstrate that the placebo effect is at least 50% of the drug effect. And if you tell people that the drug is the placebo, the drug is 50% less effective. That's amazing. And the last person at the BI is Catherine Hall, who spoke for a minute before. She should have been able to speak for much longer, who's doing incredible work on microbiology. And the last thing I want to say is that our program has lots of collaborators at the other side of the river, the Faculty of Arts and Sciences, and we have projects in the history of science and anthropology and maybe something else. Oh, and quantitative social sciences. Anyways, thank you very much.